السلام عليكم ورحمة الله وبركاته. صبحكم الله بالخير جميعا. First of all, I'd like to thank the organizing committee for their great effort to make this symposium possible. Second, it's my pleasure to introduce Prof. Amita Agrawal. She's a well-known figure in the special interest in the autoimmune diseases. Prof. Agrawal is the head of Department of the Clinical Immunology and Dermatology of the Sanjay Gandhi Postgraduate Institute of Medical Science in India. She has, as I mentioned, a special interest in autoimmune diseases with hundreds of publications and research, and she was awarded many times for her great contribution in this field. Without further delay, welcoming with me Dr. Agrawal.
Coin. If you see the common garden variety autoimmunity, there we have major manifestation of autoimmunity, and these patients are predisposed to have subclinical infections. While in primary immunodeficiency, infections are much more overwhelming and autoimmunity may be a minor feature. However, this is not always true. And it's been seen that the severity of immune defect is mild in patients with garden variety autoimmunity, while it is high in patients who present with primary immunodeficiency. So thus it's a spectrum, and each thing can merge into each other. Why do autoimmunity occur in primary immunodeficiency? Because if you think commonly, a person who has immunodeficiency should not have autoimmunity, which is a feature of heightened immune response. But however, it does occur. So it can happen when you have a dysregulated immune system. That is, the body does not develop tolerance to its own self-antigens. That obviously causes autoimmunity. Second, in patients who have antibody deficiency, because they are not able to clear infections, so they have a persistent antigenic stimulation. And as we know that persistent antigenic stimulation can give rise to clones which can react against your own self-antigen and lead to autoimmunity. Then in patients who have primary immunodeficiency, because they have multiple infections, they have tissue damage. Whenever you get tissue damage, there is release of self-antigens, and this can also trigger autoimmunity. And finally, we have a mechanism in our body to clear dead cells, immune complexes, and if you have defect in that, either in clearance of immune complexes, as happens in complement defects, or in clearance of apoptotic bodies, then there is persistence of self-antigens which can trigger autoimmunity. So we have multiple mechanisms which predispose a patient with primary immunodeficiency to develop autoimmunity. And we'll see each of them slowly and steadily. What is the prevalence of autoimmune disease in patients with primary immunodeficiency? This is a large US primary immunodeficiency data set which shows that the highest prevalence of autoimmunity is seen in patients with chronic granulomatous disease, common variable immunodeficiency, in patients who have a Nemo defect, and it's seen occasionally in patients who have A-gamma globulinemia or Dye-George syndrome. And so these are two conditions which have low prevalence of autoimmunity. And in A-gamma globulinemia, it is because that they have deficiency of all antibodies. So even the autoantibodies are very low in them. This is another data set which again shows, here they have looked at only 3 autoimmune disease. And if you see patients with chronic granulomatous disease have a very high prevalence of inflammatory bowel disease, while patients with viscoelastic syndrome have autoimmune hemolytic anemia and thrombocytopenia as the major manifestation. And in complement deficiencies, the most common manifestation is autoimmune hemolytic anemia. So it also varies from disease to disease. So why do we get autoimmunity in primary immunodeficiency? we have a very well-regulated immune system, and the body develops tolerance to self-antigens, both in the primary organs of the immune system, that is the thymus and the bone marrow. In the thymus, when the T cell is developing, there is positive selection. Positive selection means we select T cells which can recognize antigen in context with our MHC molecule. And we also have a negative selection where the T cells which recognize our own self antigens with very high affinity are actually deleted. And this is done with the help of antigens which are presented by thymic medullary epithelial cells. So we will see how it happens. So the thymic medullary epithelial cell actually expresses lots of self-antigen. So it was initially thought that how come in the thymus, antigens which are expressed in other organs of the body are getting expressed? It is only in the last few decades we have come to know that there is a transcription factor which is called IRE, which is a master regulator, and it regulates the expression of self-antigens in the medullary thymic epithelial cells. And the antigens from the liver, intestine, brain, leukocytes are expressed in very high amount, while other antigens from different organs are also expressed to a certain extent. And because in the thymus we have availability of all these self-antigens because of this transcription factor, so the developing T lymphocyte, when it sees these self-antigens and if it reacts to it, these T cells are destroyed in the thymus itself by a mechanism called apoptosis. So if you have expression of this transcription factor, the self-reacting CD4 and CD8 cells are deleted, and the cells which don't recognize the self-antigens come into the periphery, and we also generate regulatory T cells in the thymus in response to these self-antigens, and they also come into the periphery. If there is a defect in this transcription factor, there is large amount of self-reactive CD4 cells and CD8 cells which come to the periphery and leads on autoimmunity to various self-antigens as well as to the cytokines. So this is one disease which is characterized by multiple cytokine autoantibodies, and we'll see why they are important. So this is our data of autoimmune polyendocrinopathy syndrome. This is caused by mutations in the IRE gene, and patients usually present with two of these three signs. Either they have chronic candidiasis or chronic hypoparathyroidism or autoimmune Addison's disease. So we have this cohort of 22 patients. The mean age at diagnosis was around 3.5 years. And if you see that mucocutaneous candidiasis is the most common, followed by hypoparathyroidism, and then followed by Addison's disease. In addition, these patients also have a multitude of other autoimmune diseases, be it premature ovarian failure or Zika syndrome. This is data from NIH, which has shown that these patients have antibodies to many different enzymes. Almost 2/3 have antibodies to 21 hydroxylase. Almost half of them have antibodies to aromatic 1 amino acid decarboxylase. And we have also shown that a simple ELISA to detect IFN alpha antibodies can be used as a screening test for the family members and also patients who present with only hypoparathyroidism or only with Addison's disease. And by using this, we could pick up 3 out of 25 patients of IRE mutations. Why do you get chronic mucocutaneous candidiasis? This was not known because you can have autoimmunity to endocrine organs, but why are these patients having chronic mucocutaneous candidiasis? It only was revealed when it was found that these patients have autoantibodies to IL-17 and IL-22. And this IL-17 and IL-22 are major cytokines which are important for our response to candidiasis. So that is why these patients have chronic mucocutaneous candidiasis. I told you that these patients have antibodies to interferon alpha. So they should be predisposed to viral infection. However, they don't have much of viral infection because our monocytes and other mechanisms can look after the viral infection. So interferon alpha may not be as important for that. So this is a recent systematic review which has been published in this month itself, where 938 patients have been collated. Again, half of them had the classical triad, And as we saw in our series, chronic mucocutaneous candidiasis is the most common, and they have many other autoimmune diseases. Coming on to the next case, this is a 3-month-old boy who presented to us with watery large stools for 2 months. He had poor weight gain. He had dermatitis for 1 month. And on examination, he had mild pallor, seborrhea, and erythroderma. His family history was revealing. He had had 2 sibling deaths with diarrhea. Both were males. And he also was growth stunted. So it seemed that he had an X-linked disorder which was causing enteritis and dermatitis. So on investigation, we found that he had anemia, he had leukocytosis, he had inflammatory parameters raised, his stool examination was normal, so was his HIV, he had marked hyperglycemia, so he had diabetes mellitus. He also had hypothyroidism. So he had 2 more autoimmune diseases. And his immunoglobulins were normal, except he had low IgA and he had high IgE levels. So he was treated with antibiotics, insulin, thyroxine, and was given, for his autoimmunity, was given corticosteroids and cyclosporin. But his diarrhea did not improve. So we had to treat him with rapamycin. And when the mutation analysis was sent, it showed that he had FOXP3 missense mutation, because we suspected an X-linked syndrome, which is called IPAX. And he underwent hematopoietic stem cell transplantation, but unfortunately died after 1 month because of primary graft rejection, which is a very well-known phenomena in patients with IPEX. So in IPEX, what happens is that there is a defect in the FOXP3 transcription factor. And FOXP3 transcription factor is the most important transcription factor, or a signature transcription factor for T regulatory cells. I showed you that in thymus, we also develop T regulatory cells. And these T regulatory cells are supposed to cause inhibition of T effector cells in the periphery. So if your T regulatory cells are less, the T cells which are circulating in our body will cause autoreactivity against the self-antigen. So this is a disease which is characterized by immune dysregulation, polyendocrinopathy, enteropathy, and X-linked, because this gene is located on the X chromosome. So our patient had all the 4 features, and these patients can be detected using decreased number of T regulatory cells, which you can do by flow cytometry, and the mutations seen in this disease are spread all across. So think of this disease when you have a neonate who presents to you with chronic diarrhea, watery diarrhea, and has also endocrinopathies. So these, as I said, that these are the most important features: endocrinopathies, enteropathy, and endocrinopathies. So this is a story of another girl whom we saw, 6-year-old girl who presented with lymphadenopathy since the age of 3 years. She's had multiple biopsies with a diagnosis of malignancy, but all of them showed reactive hyperplasia. She also had thrombocytopenia detected at the age of 5 years, which was treated with corticosteroids. And for the last 3 months, she had arthritis. So she was referred to us with a diagnosis of lupus. Because she had good going lymphadenopathy, we thought that she may have a syndrome which we call as ALPS, that is autoimmune lymphadenopathy syndrome. And when we looked at her double negative T cells, that is cells which are neither having CD4 nor having CD8 and are having TCR alpha beta, they were increased to 8.9%. So we take it normal as less than 2%. And in this disease, you also have high vitamin B12 levels, even though the mechanism for this is not known. So this is because, as I told you, that in thymus, all the cells which are reacting against self are deleted. So how are these self-reactive cells deleted? The mechanism is apoptosis, and apoptosis is mediated through Fas ligand pathway. So when Fas ligand binds to Fas, then you get activation of this pathway, which includes caspase, and this causes apoptosis and the cell death. So you can have multiple different types of ALPS depending on what kind of molecule is involved, if it is Fas involvement, or it is Fas ligand involvement, or it is caspase 10 involvement. So the most important clinical feature in these patients are lymphoproliferation, which our patient had. Some patients can have lymphoproliferation autoimmunity. Our patient also had autoimmunity because the patient had idiopathic thrombocytopenic purpura. And the median age at diagnosis is usually 3 years, but this disease can present at any age, from infancy to 30 years of age. And there are patients who have only one manifestation. There are patients who have multiple manifestations. And the most important is cytopenias. So autoimmune hemolytic anemia, thrombocytopenia, or neutropenia. And in addition, they can also have other autoimmune diseases. Then you can have defects in lymphocyte development. We know that RAG gene is required for T cell rearrangement and B cell rearrangement. So in diseases, like we have already discussed that Ig gene, which is needed for negative selection of T cells. And if you have defects in Ig gene, you get the upset syndrome. Then in IPEX, we have defect in the T regulatory cells. But you have other defects like DGeorge syndrome, where there is decrease in the thymus is defective. So there also you can get dysregulation and you can have disease, which is, they can have autoimmunity. Similarly, in Omen syndrome, which is also a defect in the RAG gene, this can also present with autoimmunity. So RAG gene can also have effects on the B cell because it is important for B cell rearrangement. And that can also lead to increase in autoantibody production. So if in Omen syndrome, like we have this child, this is not the picture from that patient. So these children will present with early onset erythroderma, lymphadenopathy, hepatosplenomegaly. They also have diarrhea and recurrent infections. And what you find in them is they have eosinophilia, increase in IgE level, but they have marked B cell lymphocytopenia. So their B cell number is very low. And they have lots of autoreactive T cells which are circulating. And these autoreactive T cells are the ones which cause enteropathy as well as dermatitis. In the DGeorge syndrome, the common manifestation which you see is hypoparathyroidism, which is because of absence of parathyroid, but they can also have autoimmune diseases like hypothyroidism, autoimmune cytopenias, and sometimes juvenile arthritis. Now let's go on to, so this was basically the T cell defects which lead on to autoimmunity. Now coming on to the B cell defects. So we know that B cell development partly occurs in the bone marrow and partly in the periphery. And a lot of it happens after there is antigen exposure. So if you see defects, the most common B cell immunodeficiency is common variable immunodeficiency, which can occur both in adults and in children. It presents usually with infections which are respiratory infections. However, 1/3 of the patients with common variable immunodeficiency can have autoimmunity. They also have allergies because they produce a lot more antibodies, IgE antibodies to different allergens. And in addition, they can also have enteropathy. So if you see the autoimmunity in patients with CVID, almost 1/3 will have autoimmunity, and that could include inflammatory bowel disease, immune thrombocytopenia, EVAN syndrome, autoimmune hemolytic anemia, rheumatoid arthritis, and many more. If you just look at the major ones, in this another series from which was basically looking at more of hematological manifestation, almost 44% of their patients with CVID had immune thrombocytopenic purpura, and 20% had autoimmune hemolytic anemia, and 13% had both. So it means that almost 70% of their patients, so it could be a biased version because it is from the hematological unit, but they had immune cytopenias. So then patients who have IgA deficiency, just isolated IgA deficiency, which is one of the most common primary immunodeficiencies seen in the world, you can have any of these manifestations. All autoimmune diseases are actually increased in patients with selective IgA deficiency. We see it very little because in India, the prevalence of IgA deficiency is very low as compared to what you see in Caucasians, where it is 1 in 300. So this is a very good data set where they have taken 2,000 patients with IgA deficiency or subjects with IgA deficiency, and they have matched them with almost 9 times the controls. And if you see that most of the autoimmune diseases are increased at least 20-fold or 30-fold in patients with IgA deficiency. Be it celiac disease and type 1 diabetes and inflammatory bowel disease are 3 most common autoimmune diseases which are seen in IgA deficiency, followed by rheumatoid arthritis, hyperthyroidism, or hypothyroidism. And if we are looking at rheumatological diseases, then juvenile arthritis, lupus, and rheumatoid arthritis are much more common in individuals who have Iga deficiency as compared to ones who don't have it. Now coming on to the peripheral tolerance. Because nothing is perfect in human body, and some amount of autoimmune T cells do escape from the thymus. They are kept under check by the regulatory T cells, and we know that regulatory T cells express a protein called CTLA4. If you have deficiency of CTLA4, because it gives you a negative signal, the negative signal does not happen. And because the negative signal does not happen, the T cell is overreactive. And the autoimmune T cell is also overreactive. And that leads on to autoimmunity, which is directed against multiple organs and cells of the body. So they can present with immune cytopenias, autoimmune thyroiditis, autoimmune skin disease like psoriasis, vitiligo. They can also have autoimmune arthritis, splenomegaly. So they can have all of these manifestations. Similarly, again, if you have a defect in the recycling of CTLA4, that is LRBA deficiency. LRBA is protein which causes this, helps in recycling. So if there is a defect in the recycling, then also you can get similar manifestations. And lastly, that the autoantigens which are generated in the body because of wear and tear and because of apoptosis of the cells, because every cell has a limited lifespan, so you have a programmed cell death. So those need to be removed. So apoptotic cells or the debris is removed by IgM molecules as well as complements, and these are taken up by the red blood cells because of the complement receptors, and then they are cleared in the liver and spleen. So if you have defects in the complement, the apoptotic debris will not be cleared and there will be lots of self-antigens present. And similarly, the self-antigens can bind to immunoglobulins and then they can be cleared through the immune complexes. So lupus is a disease which is seen in patients who have complement deficiency. And the penetrance depends on which complement component is deficient. So if you have C1q deficiency, there is almost complete penetrance. While if you have C2 deficiency, then it is only 1/3 of those individuals actually develop lupus-like phenotype. And that is mainly because because of the complement deficiency, the immune complexes are not cleared and the antigen stays, autoantigens containing immune complexes stay and they activate the plasmacyte or dendritic cells and monocytes to produce pro-inflammatory cytokines. So is this lupus different from the lupus we see in general? This usually presents below the age of 20 years. It has predominant cutaneous manifestations and almost half of them have renal manifestations. ANA is present in a less proportion as compared to de novo lupus, where you see it in 98%. Most are anti-dsDNA antibody negative, but they have antibodies to Rho and La antigen. So they may have persistently low complement levels, so that may give you a clue. And in addition, they can have increased susceptibility to infection to capsulated organism. So if you have a young child, especially if you have lupus less than 5 years of age, always rule out monogenic lupus. There are many other defects like TREX1 deficiency and deficiency of DNase1, DNase L3. So those all can present with lupus at a very young age. In chronic granulomatous disease, because chronic granulomatous disease, you have defect in the generation of superoxides. And this actually causes, because normally superoxides help us in clearance of apoptosis and all those degradation of the phagocytose material. If that is defective, we have a lot of, and this also helps in resolution of inflammation because they take up all these things, the debris, and clear up, and the inflammation resolves. So if there is defect in the oxidative formation of reactive oxygen species, so the debris doesn't get clear and you have persistence of autoantigens, and these patients can present with, they can have increased prevalence of Crohn's like colitis, lupus, ITP, rheumatoid arthritis, and many other autoimmune diseases. And there's a very interesting phenomenon seen that the mothers who are carriers of X-linked chronic granulomatous disease, 2.7% of them developed discoid lupus. And in this US registry, 9% of families had some or the other autoimmunity. Mostly have photosensitivity, oral ulcers, joint pains. And the mechanism, as I showed you, probably these women, even though they are carriers and they're not susceptible to infections, but they probably clear the apoptotic bodies less. However, in Taiwan, this is a recent study where they looked at 23 carriers of CJD. They do not find any evidence of autoimmunity in them. Then the other clinical manifestation of autoimmunity can be very early onset inflammatory bowel disease. And so if you have a child who presents with very early onset, that is less than 6 years of disease age, always try to exclude immunodeficiency in them. So this is our experience. Out of 48 children with very early onset IBD, we could diagnose immunodeficiency in 4 of them. And I presented you that case of IPEX syndrome. And you can see this in IL-10 receptor defect, severe combined immunodeficiency, common variable immunodeficiency, ALPS, and in many other conditions. So thus, ladies and gentlemen, when to suspect primary immunodeficiency in autoimmune disease? Because autoimmune diseases are definitely much more common than primary immunodeficiency diseases, but we should not miss them. So if you have autoimmune disease occurring in infancy or very early childhood, always exclude. If you have a male child, we know that autoimmune diseases are much more common in young girls or women. If you have, in addition, increased infections or presence of allergic phenomena, if there is co-occurrence of these things, exclude immunodeficiency. Or you are having multiple autoimmune diseases at any age, obviously much more in younger age group, the probability of having PID is more, but even in older age group, CVID can occur at any age. And in all these individuals, take a family history because the patients don't tell you. So if there is a family history of primary immunodeficiency, it strengthens your thing. And as is true in medicine, your eye sees what your mind knows. So if you think of them, you will be able to diagnose these patients who have underlying primary immunodeficiency and are presenting to you with autoimmune disease. Because it's important to know, because you do not want to immunosuppress them heavily because they are at a higher risk of having infection. And like in CVID, if you treat them with IVIG, a lot of their autoimmune manifestations also get better. But you may sometimes need to use immunosuppression, but you will be very cautious in using immunosuppression. And in some of those, even hematopoietic stem cell transplantation may be curative. So if you diagnose them, you can provide them much better care and a better outcome. Thank you.
Thanks, Prof. Agrawal, for this nice review of a challenging subject, I should say. So the floor is open for questions. Dr. Azam, can you? Yes, sure. Okay.
Assalamu alaikum wa rahmatullah. Thank you for both excellent presentation. Dr. Azam and maybe Prof. Amita can comment. As rheumatologists, all the time we are treating autoimmune diseases. And as you know, we are using biologic very common. Now, some of these biologic agents may induce autoimmune disease. So what is the mechanism? Do we know that? We know it's described as paradoxical phenomena, but from immunologist point of view, can you comment on that? This question number one. I can ask that question two or after your answer.
So your question is, how does biologics cause autoimmune diseases, especially in pediatric population?
Even in adults.
Yeah, the question, can you just repeat the question 1 second? Which immunomodulator did you say can induce autoimmunity?
No, we are using for example, biologic agent like anti-TNF. For
Yes.
instance, we use it for other autoimmune disease. Surprisingly, they developed other autoimmune phenomena or disease.
Yes.
So what's the explanation? Maybe Dr. Azzam or you can answer that.
I
So
think the
if you take
explanation-
example of anti-IL-17, like people have shown that if you use anti-IL-17 based therapies, there is an increased risk of having inflammatory bowel disease. And so the mechanism postulated are that in the gut, IL-17 is actually a protective cytokine. Even though we know in spondyloarthropathy, IL-17 is the one which causes the manifestations. So those patients, if they have spondyloarthropathy related with IBD, their spondyloarthropathy may improve, but their inflammatory bowel disease has either can get manifested or they can develop this. Then there are some other biologics, like if you use checkpoint inhibitors, which are used for patients with malignancies, because the checkpoint inhibitors are working at the mechanism which downregulate the immune response. So if you want to increase the immune response to the tumor, you also increase immune response to autoantigens. And these are the patients who are presenting with autoimmunity related phenomena in setting of checkpoint inhibitors. And they can have hypophysitis, they can have thyroiditis, they can have arthritis, they can also have enteritis. So, and they are finally treated with immunosuppressive drugs. So when we change the immune system by using these drugs, you can sometimes have autoimmunity.
Okay, Dr. Azzam, you want to comment?
Yes, I agree with Prof. Agrawal, but I think the story is different from one biologic or targeted therapy to another. So every targeted therapy targets a specific part of the immune system, and the explanation will be different from one biologic to another. So we cannot say one simple explanation for all biologic. So we have to take it case by case. This is one thing. The other thing is that not every autoimmune phenomena is a true autoimmune disease. Sometimes we see a manifestation that resembles autoimmune disease, but there is no direct evidence that is truly an autoimmune disease. For example, we see positivity of ANA in around 5% of the population, and this positivity is not correlated or not because of an ongoing autoimmunity. It is part of, let's say, residual antibodies towards self-antigen, but not to the extent that cause autoimmune diseases. So in order to make sure that we are really talking about autoimmune disease, we need to have a direct evidence of autoreactive T cells damaging the self-antigen or tissues, or a direct evidence of auto-antibodies damaging the self-antibody, the antigens or cells. So these experimental direct evidence are not easy to do, but they are available in research institutions. And for example, the proof or the direct evidence that ANA is directly pathogenic in SLE patients is taken from experimental design, where they took the fractionated and purified ANA antibodies and injected into animal models. Healthy animal models usually will manifest SLE-like picture if you infuse the pathogenic ANA from truly, or let's say, a diagnosed SLE patients. And this is the same with autoreactive T cells. Sometimes you can infuse an autoreactive T cells into a well-designed mouse model, and then you get the manifestation of autoimmunity. So the direct evidence is important to really establish an autoimmune disease. And sometimes we can see what seems like an autoimmune phenomena with some biologic, but it lacks proof or direct evidence. So like I said at the beginning, the story is different from one to another. In some cases, we have confirmed proof of autoimmunity from biologic agents, and in some cases, it's just what we call pseudo-autoimmunity with no direct evidence. So it doesn't preclude the presence of autoimmunity, but it makes us on, let's say, in a stage where we cannot say yes, there is an autoimmunity or there is no autoimmunity.
Dr. Azzam, we are talking about clinical manifestation. I'm not talking about lab or evidence confirmed by lab. For instance, we have GIA patient treated with anti-TNF. All of a sudden, few months later, he may develop uveitis, may be related to the the medication, or maybe he developed psoriasis. I know these clinical manifestations may associated with the disease itself, but after we stop the medication, the disease, the other manifestations disappear. Most likely it's related to that. So this is the point. This is what they call it paradoxical. I know you are talking about the lab result, but sometimes it's difficult to prove it for a clinician.
Yes, I agree. Sometimes the clinical manifestation is convincing enough to label the patient as an autoimmune condition related to a biologic therapy. But again, the explanation is different from one biologic to another. And I think the understanding is not yet complete regarding this, but the alteration of the immune system response itself can enable the autoreactive T cells and the autoreactive B cells to come from out of hiding into the picture. So this is my explanation.
Okay. Maybe one further questions, if you have questions.
I can ask.
Sorry.
Again, Dr. Azzam and Dr. Amita. As pediatric rheumatologists, sometimes we are receiving, not that frequent, but we receive immune deficient patient from immunology service with autoimmune manifestation. And we are in the position to start immunosuppressive medication. And sometimes we are using heavy medication like biologics, sometimes methotrexate, and maybe more. From immunologist's point of view, what's the parameters to say this is enough treatment? We don't want to suppress the immune system further. Thank you.
That's a wonderful question. It's very difficult to have a balance. The most important indicator obviously is the clinical response. So like if you're using immunosuppression for immune thrombocytopenic purpura, you don't want to over suppress the immune system. So you give it to the degree, like you start with corticosteroids. As soon as the platelet count goes up, you start tapering off and keep a close watch for infection. So these are you have to really toe a very tight rope in these patients, because you don't want them to have autoimmunity, which is causing problems, and you also don't want to over suppress the immune system. Like you saw in that patient with IPEX, we have given everything. We have given rapamycin, cyclosporin, even though the child is having immunodeficiency. So it is a difficult task, but we have to strike a balance, and most of the time you are successful. You can do a good job. And your question regarding uveitis occurring in patients who are treated with anti-TNF agents, the uveitis is seen predominantly in patients who are treated with etanercept, because the mechanism of action of etanercept is different than what is the mechanism of action of infliximab, because etanercept doesn't block the membrane-bound TNF. So that is why you see it with etanercept, but not with infliximab, which is a much more potent anti-TNF agent. And psoriasis can occur with both. Psoriasis basically gets unmasked. And that is why you see sometimes psoriasis development following use of anti-TNF agents.
I have to declare that I agree this is a challenging question. But I don't have hands-on experience with, especially pediatric. These kind of questions usually arise in pediatric rheumatology and pediatric immunology. So I'm an adult immunologist, so I don't have hands-on experience on this. But I don't think there is a magical answer to this question. It is very difficult, and it depends on the manifestation of the patients, what kind of infection they develop, their susceptibility to opportunistic infections, and so on and so forth. So it's different from one case to another. And I think the pediatric rheumatologists are in better position to answer this question more than anyone else, because they're the one who are tasked to choose which immunosuppressant or targeted treatment toward these patients, and when to updose the treatment and switch to another treatment. So from my side, I don't have experience with this.